She worked at Verde Valley Medical Center, heading up the behavioral health unit. She has written books on rethinking psychiatric drugs. She lives in Sedona. She now has her private practice in Cottonwood. And Grace really was the first one, along with her mom, Carol Jackson, who's right here. Grace was the first one who really started to open our minds on the coalition to all of this information. And you know, I know that what you are hearing today may be rocking your boat a little bit, but that's okay. I mean, our purpose was not to be status quo. Our purpose today was to challenge all of us to learn and think and challenge and question and just know what is going on in your lives and in the lives of the people that you are working with, family as well as patients, and you know, across the board. So you know, we deliberated quite a while before we went ahead with today's topic. Of course, the fact that Bob Whitaker was going to be coming up, we were like, yes, we'll do it. But we do appreciate it, and thanks to Grace for inviting Bob to be with us today. So we have our next keynote presentation right now, and the title's not up there, but I'm just going to turn it over to Grace Jackson, because you'll hear what it's about and what the challenges are. So, Dr. Jackson.
Okay, well, we have a question first. Did somebody lose a phone?
Did someone lose a phone this morning?
All right.
No?
The name might be on.
All right, are people able to hear me all right? No. It's better without it. I'll try this. Is that better? Yeah. You have to do it like that? Is that like Barbra Streisand? Really? Okay. Eat the mic. Okay. Well, I'm delighted to be here. I want to thank Barbara Luttrell and Laurie Morrison and all the coalition members for putting this together, and the Cliff Castle folks for allowing us this facility. And thank you, all of you, for coming out today. So I'm going to be speaking today about the question here, mental health problems, how well are we treating the essential causes? And let me turn this on, so Jeff won't have to keep hitting the buttons. How are we doing in 2016? We're doing very badly. I give us an F, and I'm going to be speaking to you why I give you that, I give our system the F. So the outline of the presentation today, I'm going to be speaking about what are the root causes of the symptoms that we define as, quote, mental illness. We're going to talk about the blind spot in our system today, which is the role of medications. Third thing I'll be speaking to you about today are the adaptations that occur in the body. And fourth, I'll be talking about something which is very important to me called target organ toxicity. And I know that this is probably very difficult for everyone in the room to see, so maybe what I will be doing in the future is making this presentation available on the Coalition website, and then folks will be able to review these images and some of the data that's contained in them. So we'll ask Barb Luttrell to make that possible. Thank you, Barb. What do you need moved up? The screen's not up to the top.
No, wait, the projector, just a sec.
Oh, okay, thank you.
Hold, please.
I think the answer to your question was, hey, we'll get that. Is that better?
Is that good?
Oh, I'm sorry. I love a sense of humor. That was good, Jeff. Is that better?
Is that okay?
Thank you. Thanks.
I can try.
Okay, identifying root causes. What do we mean by that? Well, imagine an iceberg, and there's a symptom which would be the part of the iceberg you see above the water, and the part that actually sunk the Titanic was the piece of the iceberg that was hit by the hull, and that's below the surface. So unfortunately, our mental health system has spent a great deal of time the past 60 years focusing on the symptoms, or I should say since 1980, the DSM-3, focusing on the symptoms instead of the cause. So I'm going to talk to you about the proper role of psychiatrists, because I am a bit sensitive to being a psychiatrist and seeing so much psychiatry done badly. And so I'd like to speak for a moment about what it is that a psychiatrist should do. A psychiatrist is, first of all, a physician. So we had to attend college for 4 years, sometimes more, depending on how slow we are. 4 years of medical school, and then 4 years of post-medical school training. That's an internship and a residency. Now this is actually 1 year more than a family practice doctor or an internal medicine physician. So a lot of people don't realize the 12 years that go into becoming a psychiatrist. And why is this important? When a person sees a psychiatrist, the doctor, an MD, is supposed to be, first of all, searching and identifying symptoms that actually originate in systems of the body or in certain mechanisms of disease. So the very first role of the psychiatrist is to look at the person from the perspective of being a doctor. And so this diagram shows the different systems of the body. The one on the right, on the far left, is the muscle system. B is the bones. I won't run through all of these. But the ones that get the most attention in psychiatry is actually C, which is showing you the nervous system, the brain, the spinal cord, and all the other nerves. So a psychiatrist has to train a great deal like a neurologist in understanding the diseases that originate in the brain or diseases in other parts of the body that can impact the functioning of the brain. Secondly, a psychiatrist also has to understand mechanisms of disease anywhere in the body and how these mechanisms may be affecting the brain or other systems of the body that can then have a ripple effect on the brain. And so what would this include? This would be things like anatomic malformations, autoimmune disorders, genetic disorders, infections, metabolic disorders, and on and on. The bottom line is there is a great deal of medicine that a psychiatrist needs to know and master, and then bring that knowledge into their visits with their patients. So let me give you an example. Suppose somebody comes to a psychiatrist's office for the first time and says, I hear voices, I feel depressed, I'm having panic attacks. The psychiatrist's first step is to say, where in the brain might something be off? Could there be a head trauma, a concussion? Could there be a seizure condition, a seizure disorder? Might there be a neurodegenerative condition? That would be something like Parkinson's disease or Lewy body disease. Going down the line, immunological, could there be multiple sclerosis? Could there be unstable diabetes? Could there be a problem with lupus or Sjogren's syndrome or rheumatoid arthritis? These are immunological disorders that can still have a big impact on the brain. Infections, metabolic abnormalities. This would include everything in the body that would be endocrine. So adrenal disorders, thyroid dysfunction, parathyroid dysfunction. We would include any dysfunctions of the kidneys or the liver. This would include things like electrolyte disturbances, low sodium, low or high potassium, low or high calcium, buildup of ammonia levels. We'd look at nutritional abnormalities, excesses or deficiencies of key vitamins. We'd look at pulmonary dysfunction if someone is not breathing adequately, either in the daytime or at night through an untreated condition like sleep apnea. We would consider tumors, abnormal cell growths, whether they're benign or malignant. We'd look at disorders of the blood vessels, inflammation, blood clots, very high, unstable, high blood pressure, aneurysms, electrical disturbances of the heart. These are all the things that psychiatry should be doing. Step 2 is to then look outside the body and to look at things in the environment. Now, what might that include? This would be things like bromine, which is a heavy component of some viscous soft drinks like Mountain Dew. I had a young man come to me one time who was hearing voices, who was drinking 4 of those liter-sized Mountain Dews each day. And so bromine toxicity or bromine intoxication can sometimes present with psychosis. You won't know that unless you ask what your patients are drinking. Drugs of abuse. Cannabis is probably the big one right now in our culture that gets a free pass. And unfortunately, with the potency of today's THC content in cannabis, a lot of our young people are really struggling with psychosis and unstable mood. And they don't have bipolar disorder or schizophrenia, they have a drug-induced problem. And that's where the treatment needs to be focused. Heavy metals, this is an issue in places especially where people are relying on well water, and they may have contamination in their drinking water. So a doctor needs to know if someone is drinking water from a city system or from wells that can potentially be contaminated. We need to know a bit about people's work and sometimes their hobbies, if they are actually welders or if they make windows using lead. We need to know about molds, organic solvents, organophosphates, and the big one, my specialty, is prescription drugs. So the blind spot in the American medical system today is that very few doctors, in my opinion, seem to pay much attention to the problems that prescription drugs can cause. So I want to take a moment to just give you a brief overview. What are the drugs that we're talking about in terms of our mental health system? And simply, there are 5 major categories or 5 major families of psychiatric drugs. There are the antidepressants. These are medications like Prozac. Antipsychotic drugs, these are the ones that you see on the afternoon advertisements, like Abilify has been a big one. Drugs like risperidone, Zyprexa, but Abilify is the one that's getting most of the ads today. Mood stabilizers, these would include anti-seizure drugs that are used in psychiatry to try and settle people who have extreme swings in mood and emotions. So these would be medicines like Depakote and lithium. Sedative hypnotics, or we call these anxiety medicines. Bob told you this morning the story about Xanax. That was a great slide, by the way. Thank you for making that. Lovely. So Xanax would be the most commonly used anxiety medicine in America still. Ativan would be another one. Valium would be another example. And then stimulants. These used to be reserved mostly for children who had been labeled as fidgety, inattentive kids. But there's been a new push to expand this now to adults as well. So those are the drugs that we call psychiatric drugs, psychiatric medicines. And I want to say a little bit about where we've been in the past and where we are today. 20 years ago, or actually more than that, back in 1990, the sale of psychiatric medications totaled about $2 billion in the United States. Fast forwarding to 2011, because this is a big business. This is what supports Wall Street and congressmen and presidents. So if we want to ask the question, how many people are really using psychiatric medicines in our country? It's about 1 in 6 males, adult men, 1 in 4 adult females, and about 5 to 7% of our children. Now this was data that was extrapolated from Medco's report 2011. And another piece of information comes from IMS Health. These are large companies that track the trends in different sectors of the economy. And this one is focusing on the use of different prescription drugs. So in 2013, 25% of the American population was using some kind of drug that year. So 13% antidepressants, 11.5% anti-anxiety, that would be like Xanax, 3.25% ADHD meds, and then the antipsychotics down below at 2%. So this is a big business, and it impacts a large part of our population. Now, the thing that really started this mess was the capsule at the top there, which is Prozac. It was approved in December of 1987, which is a popular time of year for the Food and Drug Administration to approve lots of things. It happens late in December when nobody's paying attention. And then it was brought into the market in 1988. And it immediately launched a lot of attention. On the left is the cover of a book written by a psychiatrist named Peter Kramer, which was called Listening to Prozac. Has anybody ever read that or knows of the book? And he wrote very favorably about Prozac being the beginnings of something called cosmetic pharmacology, where it could make normal people better than well. On the right, Peter Breggin, another psychiatrist, had an answer to Peter Kramer. The two Peters are duking it out, and he's saying, talking back to Prozac, he said, hey, wait a second, it isn't everything that you're being told. So already, early on, there was a divide in the field of psychiatry as to how to regard this new medication and what it was promised to do. So how many of you remember seeing this either on television or in magazines? Probably one of the best medical journals that I know of is Family Circle. Truly. So these things creep into the periodicals, and this was an advertisement for an antidepressant called Zoloft. And what you're looking at is a cartoon showing two different cells in the brain. On the left is a cell that is called a neuron. It's a nerve. It's releasing a chemical, and those little circles are showing you a bubble or a little circle that contains a neurochemical. And that one, in this case, would be serotonin. And it's traveling across to the next cell, and it's fighting depression in this case. And so the story, as Bob has already said, it's so nice coming after you because you've done all my work. The story that was sold to the public is the drugs are correcting a chemical imbalance, and this is what it looks like. This is actually the same story that was told to doctors, okay? So it's not just for the public. This is the identical story that was told to the doctors in training, and as far as I know, is still the story that is told to doctors in training. Now, I want to say that right off the bat, this story of balance or chemicals being rebalanced or made perfect is not correct, even in the acute, the immediate stages of drug exposure. This was a study that was actually done by researchers, and there have been other groups that have replicated this, looking at the effects of Prozac in lab animals. And even after 2 weeks, they found a 50 to 60% decline in frontal brain activity. Now, those of you who are familiar with the frontal lobes, this is the part of the human brain that we usually associate with impulse control and with being most human. It's the part where we sense emotions and where we actually exhibit controlled behaviors. So right off the bat, the fact that these medicines may be doing something to upset frontal lobe activity should have been of concern. And in fact, there have been many papers published by different groups speaking about something called an antidepressant apathy syndrome or an antidepressant amotivational system, where people are made flat, they stop crying, they really stop feeling. And this was a quote in this paper. It was a 65-year-old antidepressant consumer who said, "You know, I used to become unglued whenever the neighborhood kids would ride their bikes through my lawn. Since I've been taking Prozac, I just don't give up." I had to take that out because my mom said don't swear in public. Tell the little bleep to come on. I tell you, Prozac's great. This is not so unusual. If we still had Laura here, or many folks who've been on a lot of different medicines or antidepressants, they will often speak about the fact that when they finally come off of those medicines, they begin feeling again. Their passion for life comes back. All right, so that's in the acute picture. Something can go terribly wrong, even early in the course of treatment. But remember, I'm here to talk to you about what are we not doing well. One of the things that we're really not doing well as a medical profession is paying attention to what comes later. So I want to talk to you about the adaptations that occur, and I want to give you two images about how doctors are trained to think about the biology of human systems. If any of you had studied biology in high school or college, you may have heard a term called homeostasis. Have you heard that term? Okay, so it has the meaning that things try and stay at an even keel. So I use the image of a people mover at the airport. You know, it just stays stable. And that's the image, an old image, that's how we are, that we don't fluctuate much, and that's what we're really targeting. In reality, though, biological organisms are tremendously complex. And if we were to study any one of us through the course of the day, our temperature, our breathing rates, our heart rates, our blood pressure would fluctuate up and down, much more like an escalator. So the real model about our system is much more complicated. We don't stay the same. And when we introduce medications into a system as complicated as we are, those medications don't stay the same either. And the body doesn't stay the same in response to those medicines. So there is a term for this, adaptation, or what we call the cumulative potential negative effects of how the body adapts under the influence of a medicine. And so what we actually have is a problem. The medicines themselves can actually become a stress to the body. This happens in all of medicine, not just psychiatry. But we're going to talk about how it happens in psychiatry. So, how many doctors know about this, or how many doctors are taught this? I would say probably not many. It's not in the textbooks. It was never in my training program. The textbooks and training programs and even the continuing medical education programs that we have to take emphasize the short-term effects of drugs, never the long-term consequences or these adaptations. But over time, what most psychiatrists end up doing is not seeing people who come to them with initial problems or complaints. Over time, what most doctors end up chasing are the adaptations of chronic drug use. And so most people are grossly misdiagnosed anytime a psychiatrist touches that patient who's been on medicines for 10 or 20 or 30 years and says, I'm still treating your bipolar disorder, I'm still treating your schizophrenia, I'm still treating your depression. Hogwash. This is actually the appropriate time to use that depressive, not otherwise specified, or psychosis, not otherwise specified, which means we don't know what we're treating. At this point, everything's a scramble because people have been on medicines which have kicked off all these adaptations. So there is a term for these delayed effects that happen. How many of you have ever heard the term tardive dyskinesia? Okay, wow, you guys are great. So this refers to, tardive is from the Greek, meaning delayed or tardy. It means this shows up later on. And dyskinesia just means abnormal movements. And this is frequently seen with the antipsychotic medications, but I have to tell you something, this happens with every category of psychiatric medication. So if you are a provider or a patient, you need to be on the lookout for this in every one of your patients. It's not just antipsychotics. I see a lot of patients on antidepressants who have dyskinetic movements of their fingers already, and so it's with every class of medicine. Tardive dysphoria, we can speak about the adaptations that the brain makes under the influence of different medicines and say that's delayed depression. Tardive dementia, do you know the Myslobosky papers from the 80s? Okay, so in the 1980s there were a group of people very concerned about the emergence of unstable mood as psychotic patients who were typically very flat and withdrawn started to become very volatile emotionally. And guess what? The DSM introduced a new thing called schizoaffective disorder. Well, some of the providers smart enough to look at this said, it's tardive dementia, the drugs are doing it. And so when I see people who've been on antipsychotics for years and now their moods are fluctuating very much, I'm concerned about tardive dementia, and I just call it mood disorder, NOS. Okay, I know you're going to be disappointed in me, but hey, that's the best I can do. Tardive psychosis, there are adaptations that occur in the brain under the influence of antipsychotics. Even when people stay on their medicines every single day, a large number of people have relapses in terms of voices and paranoia. And this is a medication adaptation in the brain. So it's very concerning to me when I hear about judges and when I hear about criminal justice, mental health courts, saying that we have these people, we're going to release them back to the community as long as they stay on their meds. That to me is like so terrifying. Because if that's what our judges are doing, I would really have to say, I think I'd rather go to prison and not be treated than to actually get tardive psychosis. So I hope that part of the awareness from the coalition will help re-instruct our judiciary to understand the fact that there are important considerations to be made in every individual case. That the answer is not just get the, quote, crazies in jail to stay on their meds and then everything's happy again. Not so. So I want to just digress for a moment and say, what are we talking about when we're speaking about what the drugs are doing? Inside the brain, we have billions of cells, and they're divided into two major populations. Neurons, which in this picture would be the yellow cell, and then we have 5 to 10 times more cells called glia, which means glue. And so there are 100 billion neurons, I feel like Carl Sagan, there are 100 billion neurons, and 500 billion to 1 trillion of these support cells. And just to explain to you how little we know about the human brain, even in 2016, there's been very little study about what any medication does to these support cells. Yet these are the major cells in our brain. What we do know, though, from a lot of studies that have been conducted over the past 20 to 30 years, is where these psychiatric medications go in terms of their initial targets. And I'm speaking right here about what we call the antidepressants. And so at the end of the cell, this little blue box is describing the fact that these drugs are looking for docking stations, just like a boat pulling up to a pier. An electron microscope. So in this particular study, researchers exposed a lab animal to, I think this is Prozac. And they looked at the appearance of these docking stations after 1 hour of treatment, and then again after 3 hours of treatment. And what the slide on the far right is showing you, I don't think this pointer is working per se, is it? Yes, there it is. These little black dots are the targets for the Prozac. They're supposed to be out here on the surface of the cell. But after 3 weeks, a lot of them have moved inside the cell. Now, remember Bob Whitaker this morning was talking about the fact that some of these receptors are helping the body recycle serotonin. So if you lose these transporters, one potential problem that might occur is losing the ability to recycle serotonin. So that's one kind of adaptation. There are many adaptations, but I'm putting this up here just to show you that we can actually look at these adaptations in animals and then extrapolate to, gee, could this be happening in humans too? So this is a cartoon that's actually on the National Institute of Drug Abuse website. And this is again showing you one cell, a neuron, talking to the next neuron. These little pink triangles represent a transmitter, we'll call it serotonin. And what we think happens based on a lot of studies in animals is that brain function changes as the levels of essential chemicals begins to change. Those levels change. And when this happens, the brain seems to become more sensitive to relapse and to chronicity of disease. So, the next thing I'm going to talk about is, if that wasn't scary enough, there's a bigger part of the story here. And this is something that I call target organ toxicity. Now, what does this mean? Well, most doctors probably have never heard this term. It really comes out of the toxicology community. And what this means is when a psychiatrist or any doctor is looking at the effects of psychiatric drugs, we have to look at all the organs in the body, not just the brain, not just this target organ. And so if a person comes to me who is in heart failure, I'm going to think real carefully about ever giving that person an antidepressant, because I know I'm going to double their mortality risk. If a person comes to me who has diabetes, I need to be thinking about what psychiatric drugs may be making that diabetes more unstable. If a person comes to me having just had a stroke, I need to be thinking carefully about what medicines in psychiatry may raise the risk of another stroke. You get the picture. So there is one element of target organ toxicity that means what do the psychiatric drugs do to some organ that's already impaired, already in trouble. There's another component of target organ toxicity to be considered, and that is what do the psychiatric drugs do to the primary organ of concern for a neurologist and a psychiatrist, and that's the brain. So I realigned the practice of my medical practice 16 years ago, which came with some real professional cost, because the moment you start practicing psychiatry from this orientation, you don't get to work in many systems of care. So I want to talk to you about the target organ toxicity of psychiatric drugs. What do these do? Now these slides represent dozens of articles, and I've just summarized them here neatly for you. Antidepressant drugs double the risk of cardiovascular disease. That includes things like sudden cardiac arrest, abnormal cardiac rhythms, heart attacks. They double the risk of stroke. They double the risk of diabetes when they're taken long term. They raise the risk of dementia 2 to 5-fold. Antipsychotic drugs, which unfortunately at this moment are only being taken by 2% of our population, but probably are being forced by the judges on many patients in our country. They increase the risk of cardiovascular disease 5-fold. I had a patient, unfortunately, die at Flagstaff Hospital from this problem some months ago. They increase the risk of stroke 3-fold. They increase the risk of diabetes 7-fold. And they increase the risk of dementia 6 to 14-fold. Most people who've been on antipsychotic drugs don't really live into their 60s, 70s, or 80s. But there's an elephant in the room, and that is that all the classes of psychiatric drugs raise the risk of dementia. And I want to talk about dementia because our population is aging. And we're living through a very extraordinary time in the United States demographically. Between now and 2050, the numbers of people in our country who will be 65 years of age and above will reach the top. This is the retirement of the baby boomers. I'm one. And so, so this is an issue. So we want to age well. We don't want to age badly. And so this issue of dementia is going to become more and more serious and more of a crisis for the states and for the federal government to figure out what to do about this. So what is dementia? First of all, I want people to understand the fact that dementia is just a syndrome. It's a wastebasket term for symptoms. It doesn't say anything about the cause. So I'm just going to run through what are the features of dementia. It includes memory impairment. That's what most people think about. But it doesn't have to have memory impairment. You can have someone who can't use language correctly. You can have someone who has lost the ability to recognize objects or people in their house. You have the ability to failure to actually carry out certain activities or functions like dressing oneself or knowing how to actually drive or knowing how to navigate a shopping cart up and down the aisles of a supermarket. Or you can have problems in executive functions. These would be the highest functions that we associate with being an independent adult. Things like planning and organizing, balancing your checkbook, knowing to balance your checkbook, going to the supermarket, how are you going to cook your meals, this kind of thing. So these are all the features of dementia. When I talk to my patients and give lectures, I think about the brain like a Tootsie Roll lollipop. Has anyone here eaten a Tootsie Roll lollipop? Okay. How many licks can you get? I only get 2? Okay, so the Tootsie Roll lollipop is an important analogy for how doctors might think about the human brain or the nervous system. On the outside of a Tootsie Roll lollipop, you have a sugar coating, a candy coating outside. You have a Tootsie Roll middle, that's the best part, and then you have the lollipop stick. And a human brain is organized in a very similar fashion. We have the candy coated outside, the candy coating is called the cortex. We have the Tootsie Roll middle, called the subcortex, and then we have the lollipop stick, which is called the brainstem. And so when doctors think about dementias, they think about these different regions of the brain where the problems may begin. Eventually, most dementias become so severe that multiple regions of the brain are affected. Now, what most of us hear about in the news is Alzheimer's disease. We're told that this is the leading cause of dementia in the United States. Or at least we were for the past 10 years. The second leading most is at 70% of dementias, and then after that about 20% would be something called vascular dementia. That would be anything that impairs the blood flow to the brain. In my opinion, most dementias are mixed. It's not just one thing or another, but vascular dementia is way more common in a lot of the patients that I see. So on a continuum, what are we really talking about when we look for the causes of dementia? We want to know if the brain is shrinking and falling apart. And so this slide is showing you what a healthy brain looks like on the left. See all that tissue? And on the right side, look at how much the brain has shrunken. That's what an Alzheimer's disease brain looks like. And the bottom pictures here are showing you what the brain looks like on a brain scan when it has had vascular disease, vascular problems. Now I'm going to tell you where I spend most of my time and why my career has been a bit challenged. For 16 years I've been following the toxic effects of psychiatric drugs and trying to work in the system when I can to try and help patients reduce their dependence on these medicines or find alternatives so they won't have to take these medications. And here's why. This was an important study published in 2000, and the investigators were comparing the effects of many chemicals. They actually included fluoxetine, Prozac, and sertraline or Zoloft. And they exposed these animals for a period of several days. Whoops, I'm sorry. And what they found is that there was actual damage to the serotonin fibers. The serotonin neurons became kinked, and some of them dropped out. This is a very special study that was done. This slide was done with something called dark field microscopy. So it's a very special investigation. There's never been another one like it. And I tried for years to reach the research team at Thomas Jefferson University. They never called me back. But this was an important study, and it was the first evidence that the antidepressants, Prozac and Zoloft, were actually causing structural damage to the serotonin fibers of the brain. Now, why this is interesting to me, as someone who spends a lot of time with dementia, is the fact that there's a paper published by these New York University professors who looked at the serotonin fibers in patients with Parkinson's disease, Lewy body dementia, and frontal lobe dementia, and they found the same kinds of serotonin fiber deficits. And 6 out of the 9 patients in this study have been on antidepressants. So we had an indication 16 years ago that these antidepressants were causing structural harm. Now, some of you may have realized, maybe because of Bob speaking, that the psychiatric profession wants to de-emphasize the chemical imbalance theory. So the new theory about how antidepressants work is the fact that they stimulate new cell growth, neurogenesis. Now, it turns out that mammals, including us, have the ability to put down some new neurons even as we're aging. And this was kind of a novel thing, a real breakthrough 16 years ago to find this. Now, animals are a good lab study because they have no advocacy group or attorneys speaking for them as a group, so they get cut up a lot. And so when they get studied, the animals, we're looking at a part of the brain called the hippocampus. This is what it looks like in the human brain, and this is what it, bless you, this is what it looks like in a rat. And this is one of the areas of the brain that is earliest affected in Alzheimer's disease. So this is a big part of where a human being puts down short-term memory and learning. So it was felt through a number of studies that, hey, Prozac and these other antidepressants look like they're fantastic, they're magical, they put down new cells in this part of the brain. We should start using these to prevent Alzheimer's disease or to cure dementia. In fact, if you go into a lot of these papers and read them very carefully, what happens is that in patients who've been treated with antidepressants, they consistently show shrinkage of the hippocampus on brain scans. And in the one autopsy study that I found that has looked at this, Lucassen out of the Netherlands, they have more cell death in the hippocampus in humans. If we go to the lab animals, there is an induction of hippocampal cell death. So you do get some new cell growth in a young animal, but the moment you pass into older animals, they don't have the new cell growth. And in fact, a lot of the cells that are new, even in the younger animals, don't survive. So it's like me bringing bricks over to your house and dumping them in your backyard and saying, there's your new patio. If it doesn't wire and if it doesn't stick around to be built into something, it's not really helpful to the brain. And this is actually what it looks like on a brain scan. There's a term for this called leukoariosis. And these are just sometimes called WMHs, or white matter hyperintensities. These little white spots should not be there. So the more that these spots accumulate in the brain, the more a person has two things happen. One is cognitive deficits, and two is mood changes in the direction of depression. So there's a whole team of researchers that are worried about this. They call this vascular depression, but those of us who work with cognition, we call this vascular dementia too. So there actually is quite a body of research which is available and expanding gradually on how the antidepressants are, in my opinion, sparking a new epidemic of vascular dementia. This was a 2008 article published in the journal Stroke, and this is summarizing findings in the cardiovascular health study, which looked at patients in 4 different states: California, North Carolina, Maryland, and Pennsylvania. And they looked at 1,919 patients aged 65 and above who agreed to have their brains scanned. They excluded anyone who was taking an antidepressant at the time of the first head scan. And then they compared people who started to take an antidepressant versus the people who stayed off of antidepressants. And they looked at MRI scans, head scans of the brain at 2 different points in time. And the average scan interval was over 5 years. What they found is that these white matter spots, remember that picture I showed you? That worsened in 27% of the patients who did not take an antidepressant, but it got worse in 36% of the patients who used antidepressants. So that right there was an early sign that maybe these antidepressants are not only not stabilizing the vascular disease, but they appear to be worsening the vascular disease in 36% of the patients. Now, a research group in the Netherlands has published several papers on this topic. So Gerling's group in this study looked at residents in New York City and the Big Apple. And these, again, 65 patients who were 65 years of age and older who did not have dementia. And they looked at these patients between 2005 and 2007. And they asked them about their depression symptoms. Are you using an antidepressant? And what does your brain look like over time? And what they found that the antidepressants, but not depression symptoms, was associated with a smaller hippocampus and greater white matter hyperintensities. So this is the vascular disease, and this is the shrinkage of the part of the brain associated with Alzheimer's disease, memory and learning. So Geerling's group then did another study. This is looking at patients in the Netherlands this time. And they looked at 594 patients with different features of vascular disease. So people who already were known to have vascular disease, people who may have had heart attacks, high blood pressure, abdominal aortic aneurysms, strokes, or peripheral vascular disease. And they looked at their depression, medication use, and head scans. And this was a younger group, so it included people between the ages of 48 to 68 on average. And they looked at their head scans over 4 years. At baseline, 5% of the patients had used antidepressants already. Any use of an antidepressant was associated with greater total mass of these white matter changes, those little white spots. Both the newer drugs, the serotonin reuptake inhibitors like Prozac, and the older antidepressants like Elavil and Doxepin were associated with these white matter hyperintensities. And then antidepressant use over the next 4 years was associated with an increase in one location of these white matter changes. Depression was looked at also as a possible cause and was not associated with these vascular changes. So I'm going to show you what this actually looks like in the Verde Valley. I scanned the brains of as many people as I get in my practice who either have an indication to know this, or they're having cognitive problems, or if they've had strokes, and I want to see if that has progressed or healed. And I can do this probably until 2017 when Medicare says we're not paying for this anymore, Dr. Jackson, but for now I'm having an interesting lesson. So these are scans from my patients. This is a 70-year-old man who had been on Cymbalta for 8 years. By the way, just about everybody I see is on Cymbalta now for fibromyalgia. And so what's this? This is, you can tell me what this is, right? Is this normal or abnormal? This is vascular change. And so we call that periventricular. Now this man was not demented, but we're just looking at a controllable risk factor, so this will not progress. Important for him not to stay on this Cymbalta. This is a 70-year-old female who had been on antidepressants and/or Valium for 18 years. And these are those white matter hyperintensities and then the periventricular white matter changes. And this is an 85-year-old female who had taken antidepressants for about 10 years, I guess in the 1970s, and then Lexapro with Wellbutrin, because one antidepressant is really not enough, for 3 years. And this lady can no longer navigate her car successfully, couldn't really come to my office on the correct days or times, really was struggling with very severe dementia. In the old days, this would be called multi-infarct dementia. Now the radiologists really don't say anything much about these changes except to say that there are a lot of these white matter changes. So that's what it looks like. And this is probably what I see in 70% or 80% of my patients who have been maintained on antidepressants. I also want to say that in patients, I'm tired of seeing patients harmed by improper and inappropriate use of medications that so many people hand out like they are, you know, juju beans or you know, candy. Because it's not candy. So just to recap the presentation, what have we talked about? Number one, root causes. A lot of times, even when my patients go to hospitals, sometimes hospitals that are very close to us, are not receiving very thorough evaluations for what they need to have identified. And so we do not do a very good job today in our medical profession, in the hospitals or outside of the hospitals, to identify the root causes of the problems that people really have. What do I mean by this? Things like lupus, things like autoimmune conditions, things like malformations in the brain. So serious medical conditions that should be identified first and treated appropriately before someone is treated with psychiatric drugs or told that their problem is, quote, psychiatric. Secondarily, the blind spot in all of our medical culture, not just within psychiatry, is the potential harmful effects of prescription drugs.